Hello, this is Dr. Toone, and I will be recording a class on the anus, rectum, and prostate examination. The anus, rectum, and prostate examination is performed as part of an annual exam for both women and men, and you're going to inspect the sacral, coccygeal, and peritoneal area, perianal area for skin characteristic lesions, pilonal dimpling and or tufts of hair, inflammation, and any excoriation. What you're going to be using in this exam is you're going to be using your assessment skills, observation, palpation, and you're going to inspect the anus for any kind of skin lesions and tags, any kind of fistulas or any prolapses coming out of the anus. The physical exam will consist of inserting a finger to assess the sphincter tone, palpate the muscular ring for the following: smoothness, evenness of pressure against examination finger, and then you're going to palpate the lateral, posterior, and anterior rectal walls for nodules, masses, polyps, tenderness, and irregularities. How you do this is you bend the patient over and put their chest on the examination table, and you will lubricate your finger and then insert it into the anus. You've got video clips of this in your book, and you're going to palpate the posterior by putting your hand with the palm up, and then you're going to rotate around in a clockwise fashion to palpate the entire sphincter, the anal sphincter. You're going to note the size, consistency, and mobility of the prostate gland. The prostate gland is the size of a walnut, and so it's about 4 centimeters by 3 centimeters by 2 centimeters. In females, you're going to palpate the cervix and the uterus through the anterior wall for the following: size, shape, position, smoothness, and any mobility. You want to have the patient bear down and palpate for any tenderness or nodules with bearing down, and you should have a consistent squeeze around your finger when the patient bears down. There should not be any pain when they bear down. Withdraw the finger and look at the color and consistency of any fecal material, and you'll do an occult blood or guaiac if you've got stool on the finger. The anal canal is 2.5 to 4 centimeters long. It opens into the perineum, and it is the juncture of the perianal skin is characterized by increased pigmentation in the adult and the presence of hair. The lower anal canal is supplied with nerve, so it is sensitive to pain, but the upper half is not. The anal canal is normally kept securely closed by concentric rings of sphincter muscles, both internal and external. The internal are involuntary, the external are voluntary, and that's what controls defecation. The anal canal is lined with columns of mucal tissue and has just a review of the anatomy. Spaces between the columns are called the crypts, and this is where the anal glands empty, and inflammation of the crypts can result in a fistula or fistula formation. The anal canal has veins across the columns, and these veins can result in hemorrhoids, and internal hemorrhoids or external hemorrhoids, depending on where the extra pressure is on the veins. The rectum is 12 centimeters long, lies superior to the anus. The proximal line is continuous with the sigmoid colon, and the rectal ampulla stores flatus and feces. The rectal wall consists of 3 semilunar transverse folds, and the lowest parts of the folds can be palpated. The prostate, as I said, is the size of a walnut, and as the male ages, some of the muscle inside of the prostate is replaced with collagen tissue, and that's what results in benign prostate hypertrophy. The prostate has 3 lobes. The median sulcus, it has a left and a right lateral lobe, and the median lobe, which is usually not palpable. It contains active sensory alveoli that contribute to the ejaculation fluid. In infants and children, the first meconium stool is originally passed in the first 1 to 2 days after birth, and that indicates anal patency. The first stool is sterile. It's common for newborns to have a stool after each feeding, and that's the gastrocolic reflex. It's the control of the external anal sphincter is usually in 18 to 24 months, and the prostate tends to remain underdeveloped until puberty. Pregnant women have decreased GI tone and mobility, producing constipation, so dietary habits and hormonal changes are a factor there, and they will have to adjust the dietary habits to prevent this constipation that comes with pregnancy. Also, the iron that most women take during pregnancy causes constipation. The pregnant women, as I said, can have constipation, and often that is aggravated by the prenatal vitamins. There's pressure in the veins below the enlarged uterus increases, and there's a development of hemorrhoids aggravated by labor, and protrusion and inflammation can occur for these veins to develop hemorrhoids. In the older adult, you have degeneration of the effluent neurons in the rectal wall, which can lead to stool retention and increased pressure sensation threshold in the rectum. There's a loss of external sphincter tone, and this can result in fecal incontinence. The prostate is often obscured by benign prostate hyperplasia, as the collagen tissue replaces the muscle within the prostate, and this causes just a generalized benign hyperplasia of the cells, and there's a loss of the secreting alveoli in the prostate. So let's review the related history. You need to ask about changes in the bowel, such as changes in the number, frequency, and consistency of stools, or any presence of mucus or blood. And you would ask about the color of the stool. You're going to ask about the onset and duration of symptoms, if there's any aggravating or relieving symptoms, and any medications that they're on, such as iron, laxatives, or stool softeners. And be sure and include over-the-counter medications like Pepto-Bismol, because that will result in turning the stool solid black. You want to ask about any anal discomfort, itching, pain, stinging, or burning, and its relation to body position and defecation. If the pain is relieved with defecation, or if it's worse during defecation. If it's worse during defecation, you might have an anal fissure, And if it's relieved after the defecation, then you've got something in the lower colon. You want to find out if they're having to strain to have stools, the size and shape of the stools, and any interference with activities of daily living or sleep, if they're having to get up at night to defecate, or if they're having so many stools that they're constantly having to look for a bathroom. And you want to find out what kind of medications they're on, and if any of them are hemorrhoid preparations. You want to ask about rectal bleeding, the color, if it's bright or bright dark and black. If it's related to defecation, the amount, the changes in the stool, changes in the size of the stool, if it's ropey or if it's normal stool consistency, any associated symptoms, and if they're taking any iron or fiber additives or stool softeners. In the males, ask for a change in urinary function, such as the history of enlarged prostate or prostatitis, and if there's any symptoms like hesitancy, urgency, nocturia, dysuria, change in the force or caliber of the stream, dribbling, or urethral discharge. Ask about any medications, any antihistamines, anticholinergics, tricyclic depressants, or any 5-alpha reductinase inhibitors, as this can all change the functioning of the prostate. You want to ask about hemorrhoids, spinal cord injuries, and any kind of lower back problems. You can ask if there's any kind of carcinoma or benign prostate hypertrophy in the family. Females, you want to find out if they've had episiotomy or 4th grade laceration during delivery, and any colorectal or related cancers, such as breast, ovarian, or endometrial. On the family history, ask about rectal polyps and colon cancer or familiar cancer symptoms and prostate cancer. Under personal and social history, you want to find out if there's any travel to areas of high parasitic infections, and this can be zones within the United States. You also want to look at diet, the amount of fiber and the amount of animal fat. You want lower animal fat and higher fiber diet. The colorectal or prostate cancer risk factors, like African Americans are twice as likely to have colorectal cancers than white, and the use of any alcohol. On the infants and children's, you're going to look at stool characteristics, bowel movements accompanied by crying, straining, and bleeding, and any feeding habits, bowel control and potty training, any associated symptoms and congenital abnormalities. On pregnant women, look at the gestation and estimated delivery date, what kind of exercise they do, fluid and fiber intake, and if they take any kind of vitamins or supplements. Older adults, you're going to look for change in bowel habits or characteristics with associated symptoms, as in dietary changes. And in the males, you look for enlarged prostate and urinary symptoms, which are frequency in urination. If they're having to get up at night to urinate, if they're having trouble starting and maintaining their stream of urine. So the examination, what you're going to use is gloves, lubricant, pen light, drapes, and the occult blood test. You want to position the patient by putting them in either the knee chest or the left lateral of hips, or the most common is standing with hips flexed and the upper body supported on the examining table. Bend over and put your chest on the examining table is the most common position. You're going to look for lumps, rashes, inflammation, excoriations, scars, pilonal dimpling, or tufts of hair in the pilonal area. And you're going to look at the sacrococcygeal and perianal areas for tenderness, inflammations, any abscess, fistulas or fissures, any cyst, or if they have any itching around the anus. You're going to inspect for lesions, tags or warts, external hemorrhoids, fistulas, and you're going to have clock references to describe the location. 12 o'clock is the ventral line and 6 o'clock is on the dorsal midline. Here's a picture of the anus with all the structures identified. You're going to look at the sphincter tone, the external sphincter tone, and see if there's a lax sphincter that can indicate neurological defect. You have an extremely tight sphincter can result from scarring or spastic caused by a fissure or other lesion, inflammation, or just generalized anxiety about the exam. One of the things that helps them to relax the anus is have them push down on the table with their abdomen, and that will relax the anus. The rectal pain is almost always indicative of a local disease. Look for if it's irritated or if there's any hard rock, constipation, rectal fissures, or thrombosed hemorrhoids. You wonder on the sphinctal area if you always have urge for in the rectal vault, if you have an infant that has constipation, but when you palpate in the rectum, you have an empty rectum, then you really need to evaluate that baby for Hirschsprung's disease. The external sphincter tone can have a lax sphincter indicating a neurological defect. An extremely tight sphincter can result from scarring or a spasticity caused by the fissures or other lesions, inflammation, or anxiety about the examination. Or rectal pain is almost indicative of some kind of local disease like irritation, rock-hard constipation, rectal fissures, or thrombosed hemorrhoids. Assess the anal ring for tone and texture. It should be smooth and exerts even pressure on your finger when the patient bears down on your finger. You will look for nodes or any irregularities. So this is just a picture of putting your finger in the rectum and having them bear down. You also have video clips in your book. The rectal walls, you're going to look at the lateral and posterior wall for nodules, masses, irregularity, polyps, and tenderness. And you're going to feel if there's any internal hemorrhoids. And they're not ordinarily felt unless they're thrombosed. An internal hemorrhoid feels like a raisin that is attached. And it normally doesn't hurt to touch them. But if they're thrombosed, it does hurt to touch them on the inside of the rectum. On the anterior, you're going to have contact with the perineum and perineal inflammation. There's the nodarity of peritoneal metastasis and self-lesions. The posterior surface, you're also going to notice the posterior surface of the prostate. The prostate itself, look for the size, contour, and you're going to feel the two lateral lobes and the median sulcus. Look for consistency, mobility, and tenderness. If you get your finger and you go ahead and adduct the thumb to touching your pinky finger, and which is your fifth digit. If you feel on the thumb side, you will feel that the amount of firmness that you feel on your thumb muscle will be what a normal prostate will feel like. If you feel under your palm on your fifth metatarsal, metacarpal, you will be able to find that's what a benign prostate hypertrophy feels. If you feel over a knuckle, that's what cancer feels like. This is commonly referred to as the Boy Scout salute, and this will allow you to know what a normal prostate should feel like. So here's just a picture of the prostate gland and the anatomy around the gland. Here is palpating the prostate gland and how you will palpate it. On the uterus and cervix, you will feel it if it's retroflexed or retroverted, is usually palpable through the rectal examination. The cervix may be palpable through the anterior rectal wall. Stool, you're going to look for color, blood, pus, and mucus. And on the infants, you're going to inspect the anus, perineum, and buttocks. Any kind of redness or irritation, any kind of mass, discharge or bleeding, or perirectal protrusions. You're going to look at the tone, texture, and anal contraction, which should be smooth and symmetrical. On infants, you're going to notice the patency of the anus. And if you touch around the anal opening, it should produce what's called an anal wink, where the anus will wink on one side. It's a lack of contraction may indicate a lower spinal cord lesion. And routine inspection in the anal region and peritoneum for redness, mass, or swelling. You're also, rectal examination is not routine for infants and children. You do a rectal examination for any kind of pain, bleeding, rectal protrusion or abscesses, stool abnormalities, and the rectal examination is routine for adolescents. Pregnant women, you're going to look for stool changes, the hemorrhoids, the size, extent, discomfort to the patients, or signs of infections and bleeding. And older adults, look for decreased sphincter tone, stool characteristics, enlarged prostates and polyps, and any abnormalities. On the surrounding skin, look for a pilonal cyst, which is loose hairs. They penetrate the skin in the sacrococcygeal area. Any anal warts or condyloma acuminata, and the results of the infection of the HPV virus. Any anal cancers, they're often squamous cells, which can be associated with HPV. And any basal cell carcinomas or malignant melanomas that would be around the anus area. Pilonal cyst is a picture here, and you're going to see the tuft of hair. And this is the anal warts. You're going to look for perianal or perirectal abscesses for an infection. They're usually polymicrobial, and they can you can have an anal rectal fissure and tear in the anal mucosa. Look for any kind of inflammatory tracts that runs the anus or the rectum and opens into the surface of the perianal area. And look for causes of drainage or perianal or perirectal abscesses. And if they have any itching around the anus, commonly caused by fungal infections in adults or pinworms in children. Here is an anal fistula. Hemorrhoids, external hemorrhoids, or varicose veins that originate below the anal rectal line and are covered by anal skin, and internal, that they originate above the anal rectal junction and are covered by rectal mucosa. And so here's some external hemorrhoids. Picture To the left is the prolapsed hemorrhoids, and to the right is your internal hemorrhoids. Okay, polyps. They can occur anywhere in the intestinal tract. They can be malignant or benign, and they can be indicative of renal carcinoma. Adrenal carcinomas compromise the large majority of the rectal cancers and rectal prolapse through the muscular wall and the anal ring. The prostate. On the prostate, you can have prostatitis or benign prostate hypertrophy or prostatic carcinoma, and they develop from the glands within the prostate itself. Prostatitis is where you've just got an inflammation of the prostate, and it is causing constriction on the urethra. Therefore, you have the problems of starting the stream of urine, maintaining the streams of urine, and urgency and interrupted urine flow. Benign prostate hypertrophy is where the prostate muscle has been replaced by collagenous material, and so it is always inflamed. In children, you have the ringworm and pinworm. They can live in the rectum or the colon and emerges into the perianal skin layers and lays eggs while the child sleeps. And that has a lot of perianal itching. And you can have imperforate anus, where the rectum may end blindly, be stenosed, or have a fistula connection to the perineum, urinary tract, or in females, the vagina. So here are the various rectal disorders that you have in your book relating to how much of the rectum and how connected it is. You have at the end of your chapter several disorders. You need to review these disorders. And it's important that you know the PSA screening. And so PSA screening and for prostate cancer screening, which includes a digital rectal exam, which is what you would always do. If there is any kind of suspicion, you'd always do a digital rectal exam. PSA is normally done at 50, but it can be at 40 in high-risk individuals. And that would be African Americans. And but if there's any kind of suspicion at all about any prostate problem, you would go ahead and repeat a digital rectal exam. One of the examples of when you would do a digital rectal exam is if you just have a change in the shape of the stool. You can go ahead and do a digital rectal exam and see if you're finding any prostatitis or any kind of edema, or you can't find the median sulcus of the prostate. You'd go ahead and do that digital rectal exam. And prostate cancer tends to be generally painless, and you'll need to know the signs and symptoms of benign prostate hypertrophy. Thank you, and this is the end of this recording.